Test, test. Good morning, ladies and gentlemen. I tried very hard to finish the respiratory tract infections after about 3.5 hours of podcasting yesterday. It was clear to me when I replayed them that there was no sound in any of these podcasts, so that was a waste of about 3.5 hours after testing everything pretty nicely. For reasons I don't understand, sometimes when you try to record certain things, the computer completely resets the sound levels. I don't know why it does that. Doesn't matter how often or how consistently I test sound levels. All the recordings I did yesterday, the sound was very, very, very faint. You couldn't hear it. No matter how much you turn the sound up, it couldn't be heard. You just heard this muffled whisper like I was in the other room. So that all has to be redone. It will be redone, Lord willing, tomorrow. And if the sound actually works on it, those will be posted. In the meantime, we're going to go on to chapter 23, which consists of GI infections. All right, let's have a word of prayer, then let's dig in. Father, thank you for this cold day. Thank you for this very cold classroom where I'm giving this. Thank you. This is our last week of classes. Help us be consistent and stay with it. In Jesus' name, amen. Very good. If you have any questions during this time, please unmute yourself and say so, because if you give me a, if you send a text, I probably won't see it. So just unmute yourself and ask a question. So the GI tract is a continuous tract throughout our body. It has openings at the nose and the mouth, and then they connect through the naso and oropharynx. It goes from the pharynx to the esophagus, stomach, duodenum, jejunum, ileum, and then into the colon, the ascending transverse, descending sigmoid, and rectal colon, and then out it goes. It's colonized by a normal flora. That normal flora is hugely important for competitive exclusion. For this reason, we will see that prior antibiotic treatment can predispose you to certain GI infections. Different parts of the GI tract are colonized by different normal flora. And these normal flora, again, serve a very important role in competitive exclusion. In many cases, these normal flora actually play a role in aiding and abetting our own digestion and absorption, particularly in the colon when it comes to the absorption of B vitamins, in particular vitamin B, and also in the synthesis of vitamin K. So we'll start with the oral cavity. Dental plaques are caused by bacteria that adhere very tightly to the enamel. They then ferment sugars and produce organic acids, the biggest one being lactic acid. That accumulation of lactic acid etches the teeth, eventually causing a dental carie, otherwise known as a cavity. The biggest culprit here is Streptococcus mutans. Other viridans, Streptococci, can play a role, but definitely Streptococcus mutans is the biggest culprit. When it comes to the formation of dental caries, by cleaning the teeth regularly with brushing and flossing, and also drinking plenty of water, making sure you're swishing the mouth out with water and what have you, using also dental washes and what have you, mouth washes, so on and so forth. You can decrease the numbers of these bacteria on your teeth. You'll never get rid of them totally. Fluoride kills the organism and also decreases the numbers of these organisms on your teeth. I tried to have somebody online tell me that brushing your teeth decreased saliva and therefore it was worse for your teeth than brushing. I don't know if any of you have heard that, but that's hogwash, because your salivary glands make new saliva. They make it instantaneously. So the strep mutans makes a dextran capsule. Dextran is very sticky. It causes these organisms to stick to the teeth very, very effectively. So by seeing your dentist for cleanings, brushing regularly, using mouthwashes, and also restricting your diet to foods that contain largely complex carbohydrates rather than simple sugars. The synthesis of dextran is greatly aided by the eating foods rich in simple sugars, in particular fructose. So eating foods rich in fructose will increase the amount of dextran that these cells make. They also increase the cell division rate of Streptococcus mutans. They grow faster, they make more dextran, and fructose-rich foods aid in the formation of dental caries. So you can see here there's a child getting a fluoride shower with his or her teeth. That protects your teeth as well. Good oral health can actually help with good cardiac health, because poor oral health leads to poor cardiac health, simply because these bacteria can go from the teeth to the bloodstream to the heart. So good oral health is very important for systemic health. And if you fail to brush properly and have regular cleanings, you get this compilation of dead bacteria, calcium deposits, and cells that hardens into what's called dental plaque. If it gets reinforced with calcium, it becomes known as dental calculus. And this is cleaned by the hygienist at your dentist office with a ultrasonic cleaner or with a pick. If you don't get this cleaned, this can go to the gums and irritate the gums. The gums can then start to recede. If the gums recede, the bone around the tooth will start to recede as well. And the tooth then can become loose. So this irritation of the gum is called gingivitis. In the pit of the tooth, you have a mixed population of bacteria. And if the gum gets irritated, that population can increase in size and numbers. And that can cause periodontal disease, leading to something that's colloquially called trench mouth. And this can lead to teeth falling out, and you'll need root canals and things like that. So this chap here has a case of mumps. Mumps is a viral infection that initially, at least, attacks the upper respiratory tract. It later affects glandular tissue. It is transmitted by saliva or other bodily secretions from an infected patient. After it enters the host, it replicates in the lymphoid tissue in the respiratory tract. The receptor for the virus is sialic acid, which is found in abundance in just about every cell in the body. So you get a viremia that occurs before the appearance of symptoms. Hematogenous spread brings the virus to the salivary gland. Virus begins to be shed from the salivary gland about 9 days after the original infection. Incubation period is 16 to 18 days. It can range from 12 to 25 days from exposure to the onset of symptoms. Mumps begins usually with a few days of fever, usually a low-grade fever, but that can vary. Headache, myalgia, muscle aches, fatigue, and anorexia. These manifestations are followed by the salivary gland swelling that you see here within 48 hours. This is called parotitis. Parotitis, because it is the parotid salivary gland that is most obviously affected. You can see down here that also the sublingual gland is affected as well, but the parotid gland is most obviously affected. In children between ages 2 to 9, may also get an earache, and it can be unilateral or bilateral. Parotid swelling usually lasts about 10 days. Mumps is usually self-limiting. Individuals recover completely within a few weeks. Asymptomatic infection is the case in about 15 to 20% of the cases. Asymptomatic infection is more common in adults than children. It can potentially infect many other tissues. Infection of those other tissues is rare, but herein lies the complications of mumps. So 10 to 14 days after salivary gland involvement, patients may become severely ill and may even die from the illness. Now, this is rare, but it can occur. In males, a complication of mumps can be orchitis, or infection of the testes. This can be quite painful. It can lead to sterility and impotence, but that's rare. A vaccine to mumps has greatly reduced the incidence of mumps in this country. You still see it in other countries. You'll see it in immigrants, and you'll see it, of course, in non-vaccinated populations. We've talked about thrush already, so I will just simply note that a thrush is very common either in children who have poor oral hygiene or in people who are immunosuppressed. So HIV patients will more often have thrush than people who don't have HIV. Recurrent thrush sometimes is a tip-off. Someone may have HIV. So it's kind of protocol in some hospitals. If someone comes in with thrush a couple of times, they should be tested for HIV. Some hospitals, in fact, if you have thrush, they test you for HIV right away. I personally think that's probably a better strategy, but that's my opinion. So you have two main forms. You have the white oral candidiasis with the pseudomembranous candidiasis you see here, or you can have the acute atrophic candidiasis, which is an erythematous oral candidiasis. We talked about treatment for this: oral nystatin, nystatin troches, miconazole oral gels, clotrimazole troches, what have you. Nystatin is very cheap, but it's the least effective. Enterotoxicosis refers to food poisonings. So the organisms, in this case, the organisms don't cause the condition. Instead, it's toxins produced by the organisms that cause the condition. So antibiotics are not used to treat these conditions. The toxins are not detectable. They don't have color or taste or odor. Very often, these toxins are heat stable, so cooking the food will not destroy the toxin. Staphylococcal enterotoxicosis is caused by strains of Staph aureus that make the enterotoxin, staphylococcal enterotoxin. You get these organisms on the food from unwashed hands, or hands that touched unwashed surfaces, or unwashed utensils that then touch the food. So you get it from hands that touch food, or eating with unwashed hands that contain the strains of Staphylococcus aureus that make the toxin. This is characterized by the fact it comes on quickly and it resolves quickly. So it comes on about 1 to 6 hours after ingestion. You also recover between 2 to 8 hours from this malady. Comes on quickly, leaves quickly. Those are the features of staphylococcal enterotoxicosis. You have abdominal pain, nausea, vomiting, diarrhea. It's self-limiting. Treatment is supportive. In cases of extreme dehydration, which you may see in children, fluid replacement may be necessary. You might also require this in elderly patients or cancer patients who require fluid replacement. Clostridium perfringens makes the so-called theta toxin. Theta toxin upon sporulation. You find this organism in undercooked meats or gravies that are kept warm for long periods of time. So restaurants will find this if you in smorgasbords, where you get meats sitting in gravies that are just heated. They're just warmed. That's usually when you'll see Clostridium perfringens enterotoxicosis. You get onset of symptoms 8 to 24 hours. After ingestion, the symptoms will last 12 to about 24 hours. The C strain of Clostridium perfringens, C as in Connecticut, will cause a much more severe disease called necrotic enteritis. Necrotic enteritis. In this case, the organism will invade the intestinal mucosa. This results in death and eventual sloughing of the intestinal mucosa. In this case, you'll have rectal bleeding and blood and intestinal mucosa in the stools. Severe cases of this disease, necrotic enteritis, can be fatal in some cases. Otherwise, the disease is just like staphylococcal enterotoxicosis: nausea, vomiting, diarrhea, abdominal pain, and it's self-limiting. I'm going to skip Clostridium botulinum just for a bit. Bacillus cereus causes food poisoning in 2 stages because it makes 2 different toxins, a fast-acting and a late-acting toxin. The first hits at 4 hours after ingestion, the second at about 17 hours after ingestion. First one will cause severe nausea and vomiting. The second will cause abdominal cramping and diarrhea. So this leads to those split symptoms, and that's caused by Bacillus cereus. This usually also, this is a soil organism, so you get it from contaminated hands that goes to food and so on and so forth. Pseudomonas cocovenenans causes so-called bung crick disease. Bung crick disease. That's B-O-N-G-K-R-E-K. Bung crick disease. This is found largely in Indonesia, and it's named for a coconut delicacy with which it's associated. So bung crick are these flat white cakes of pressed coconut, and they're fermented with the fungus Rhizopus oryzae. The cakes are then wrapped in banana leaves. During the fermentation, and the banana leaves are sometimes contaminated with Pseudomonas cocovenenans, which overgrows the fungus in some cases. And this is a heat-stable, unsaturated fatty acid, and it will produce hypoglycemia, severe spasms, and convulsions. In some cases, it can even cause death. So if you have the opportunity to eat bung crick, don't. Don't. That's my advice. Don't. We will talk more about Clostridium botulinum when we get to the nervous system. Clostridium botulinum is found in, it's an anaerobe, so it's very commonly found in canned goods. The organism does not like pH foods, so a lot of your tomatoes now are very acidic to prevent its growth. It produces a very powerful neurotoxin called botulinum toxin. Botulinum toxin will cause a flaccid paralysis. And if you work in family medicine or peds, you sometimes get these babies who come in who don't feed, and they're flaccid. They have very poor muscle tone. They can't latch on to the breast to feed. And as you interview the parents, it turns out that either a little brother or sister or the parents are feeding the baby honey, because the Clostridium botulinum spores are in the honey, and the baby's normal flora are not developed enough to prevent the colonization of the GI tract by Clostridium botulinum. So you feed a baby honey before a year of age, and that's called infant botulism. That can be very severe. It's treatable, fortunately, but you never give babies honey. Never. Even though babies may love it. We now come to a stretch of gastrointestinal diseases that are caused by enteric bacteria. So these are gram-negative rods. They are members of our normal flora. They are opportunistic pathogens. However, some members of these species acquire particular characteristics because of transformation, conjugation, or transduction that allows them to cause disease. And some of the gastrointestinal diseases that some of these organisms cause are truly frightening. Truly frightening. Others of these will cause other opportunistic infections. So we'll talk about the gastrointestinal infections here. Just keep in mind, they can also cause ventilator-associated pneumonias. They can affect catheters. They cause urinary tract infections. We're going to talk about the GI infections here. So, enteric bacteria are commonly resistant to bile salts. In fact, let me Let me go to our little makeshift chalkboard here. All right, so your enteric so they're gram-negative rods. They stain pink on a gram stain. They're resistant to bile salts. You saw that in the laboratory. We use McConkey media that has bile salts in it. These things grew with abandon. They have LPS, so they have lipopolysaccharide. In fact, they have a so-called O antigen. And this O antigen is a endotoxin. And if these organisms get in the blood, they can cause very high fevers. Because these endotoxins cause the release of interleukin-1 from lymphocytes and monocytes and other types of cells. Virtually all of them, except for Shigella, have flagella. So they are motile. In fact, usually very highly motile. They have pillae for conjugation. And they have fimbriae for adhesion. So they're very good at adhesion. They also have iron chelating proteins that they make. So they're very good at snatching iron from our body. These are called, now, some of these are not proteins. Some of these are small molecules. So let's say molecules. So proteins or molecules, these are called siderophores. Siderophores. And then many of these enteric bacteria make capsules. In fact, there is a capsular antigen that's very common. It's called K antigen. And these are antiphagocytic. Now, your white cells can phagocytize these organisms if they're opsonized, but if they're not opsonized, you're not going to get very good phagocytosis of these organisms because of the capsules. Now, another feature that we're going to see with these organisms is they're going to use a type 3 secretion system Why is this important? And a type 3 secretion system essentially looks like, this essentially is the same setup as the flagellum. If you attach a hook and a filament to this, you get the flagellum. You take that off and put an injection piece up here. Now this becomes an injector system This is going to inject toxins into cells. So by injecting cells with toxins, my pens are dying on me. Cells with toxins, you can get the cells to change their behavior and aid and abet your growth and colonization of the human body. So these are very common in enteric bacteria. So just to keep in mind. Here's some data I just thought I'd share with you. This is from Up to Date. This gives you an idea of the, no, it's not very well focused, is it? There we go. These are the percentage of gastroenteritis infections caused by the different species of enteric bacteria. So as you can see, the pretty clear majority of gastroenteritis infections caused by enteric bacteria are caused by Escherichia coli, almost half. Now, at least when it got associated with bacteremias. That is, if they manage to breach the GI tract and cause bacteremias. Then we have Klebsiella, Enterobacter, and the Proteus, Serratia, Citrobacter, and then others. These are usually due to hospital-acquired pneumonias. These are usually due to enteric infections. These are enteric infections, but these can also come from catheters. And so on and so forth. Let me pause right here if you have any questions, anyone? No? All right, let's talk first about Salmonella. So, Salmonella come in lots of different species. The ones that tend to be important for human medicine are Salmonella enterica, and Salmonella bungori. That's B-O-N-G-O-R-I, bungori. And then typhoid fever is caused by Salmonella typhi. Salmonella typhi. Salmonella enterica. The classification of this organism was kind of up in the rafters. There were lots of different species. Now it seems as though there are probably 6 different subspecies of Salmonella enterica. They used to be all classified as different species. So if you read old papers, you'll get these different species like Salmonella typhimurium, Salmonella choleraeus, Salmonella enteritidis. Now those are all subspecies of Salmonella enterica. So that's, if you read papers and you see those names, they're now all classified as Salmonella enterica. So Salmonella will cause a gastroenteritis. It will cause an enteric fever, in which you have a systemic illness with abdominal symptoms and fever. It'll cause a bacteremia, an endovascular infection, that's your typhoid fever. It can cause an asymptomatic chronic carrier state, as you have with typhoid Mary. And then it can also cause a focal metastatic infection, such as an osteomyelitis or abscesses. All right, let's talk about the non-typhoidal infections of Salmonella, the Salmonellosis. These are food-borne infections. Global burden of these are about 94 million cases and over 150,000 deaths yearly. They're particularly high in Asia. You get them from poultry, fish, egg products. You can get them from fresh produce, meat, including beef and dog food. You can get it from fish or even milk, nut butters, spices, other foods. You can get it from animal contact, particularly reptiles, amphibians as well. You can get it from sick pets and pet food. And you can get it from person-to-person contact. There's lots of ways to get this disease. So the ingested microorganisms have to traverse the acidic barrier of the stomach. They survive poorly in the pH of the stomach. But if they're exposed to a moderately acidic pH before ingestion, that tends to adapt them to low pH. This is called the acid tolerance response. Disruption of normal flora can increase your susceptibility to this infection. That's why human patients treated with antibiotics will suffer more severe salmonella infections than those not treated properly with antibiotics. So the first part of the infection is adhesion due to Fimbriae. These organisms will then invade. They tend to invade the cells in the so-called Peyer's patches. Peyer's patches. So I hope you remember we talked about the gastric-associated lymphoid tissue. And so in the GI tract, part of the gullet, you have these so-called Peyer's patches. And these Peyer's patches consist of a macrophage-like cell. So you have this this is called an M cell. That stands for microfold cell. So these salmonella they will attach to the microfold cell. They will then enter the microfold cell. On the other side of the microfold cell is a T cell. And this T cell then is going to respond to the antigens that will be presented here on the basal surface, and that is going to elicit the immune response essentially to this organism. Now, these salmonella are also going to induce these other cells to take them up. So these will actually invade these other cells. This invasion is very interesting. I don't want to get into the deep weeds of how they do it. There's been a lot of work on this invasion mechanism. By these cells, they use the type 3 system to rearrange the cytoskeleton. They form a little vesicle and they divide inside this little vesicle. These little vesicles then can actually cause the cells then to be transferred laterally to other cells. It's really quite interesting. And these cells can also survive, therefore, inside macrophages. Consequently, and the macrophages can potentially take it just about anywhere. So usually some 10 to 14 days after ingestion, you have gradual onset of symptoms. And those symptoms are fever and headache, myalgias, and malaise, and then anorexia, and these organisms can colonize the gallbladder. If they do that, they will induce a carrier state. Now, with typhoid, essentially, these organisms are essentially going to cause a bacteremia. And you get very, very high fevers. And these fevers are so high, they can be even above 104. And the patient can become delirious. So the different types of infections, you can have a simple gastroenteritis where you get some invasion, some sloughing, and what have you. You can have others where you get attachment dying off. Others, you'll get some invasion, and then it goes away, and then you get the typhoid, where you actually get the bacteremia. So these infections, they're essentially graded with your Salmonella typhi causing your typhoid fever. Treatment of Salmonella is really hard because of lots of antibiotic resistance. So fluoroquinolones still work, but we're seeing MIC creep. That is, minimal inhibitory concentration is continually increasing. So you have to use higher and higher dosages of fluoroquinolones to treat this organism. Third generation cephalosporins will still work. Ceftriaxone, cefotaxime, but we're seeing MIC creep with those. Azithromycin works, but again, we're seeing MIC creep as well. Bactrim plus ampicillin works for some particular serovars, not all. If your patient's immunocompetent, you treat for 14 days. If your patient's immunocompromised, then you have to treat for 4 to 6 weeks. And that, folks, is Salmonella. It looks to me like it's time for our break. So we'll go ahead and take a break, take 5 minutes, and then come back after 5 minutes and resume. Boy, we're a little bit down in numbers today. Wonder where is everyone? Very good. It is time to resume. Our next organism I want to talk about is Shigella. Shigella is very clearly a subspecies of E. coli, but because its clinical profile is very different than E. coli, it's justified in giving it a species of its own. Genetically, however, it's a lot like E. coli. The disease that it causes is like enteroinvasive coli. You get person-to-person transmission. It's essentially the fecal-oral transmission system. And so this is the result of transmission from unwashed hands and food that is handled by unwashed hands. You could say kind of the 4 F's. So it would be, well, that doesn't show up very well. That show up better? Oh, a little bit. So essentially it would be fluids, fields, because if your food comes from agricultural fields that were contaminated with fecal material that came from an infected person, so fluids, fields, flies, and fingers. So the 4 F's are responsible for this transmission. Shigella is pretty common in daycare centers. It's pretty commonly seen in children. And if you work in peds, or if you work in family medicine and you see a lot of kids, you're at risk for contracting this infection. So those of you who end up going into peds, those of you who end up going to family medicine, keep in mind, have this infection on your radar, because it's not a very pleasant infection to get. Now, Shigella secretes a very powerful toxin called Shiga toxin. This is a protein synthesis inhibitor. It degrades actually one of the ribosomal RNAs, so it damages the colonic epithelium. If the toxin is absorbed into the blood, it can cause kidney damage and cause a condition called hemorrhagic uremic syndrome. So you get bloody abdominal cramping, severe cramping. Bloody stools, diarrhea, and fever. You may even get abdominal cramps, lower abdominal cramps, and then tenesmus or straining to defecate, and abundant pus and blood in the stools. So it can really freak the patient out. And in some cases, people can lose a lot of blood because of the elaboration of Shiga toxin. Treatment is, I would say, straightforward, except that resistance levels are climbing. So fluoroquinolones, moxifloxacin, levofloxacin. Those are, if efficacious, so are macrolides, azithromycin, clarithromycin, several different types of beta-lactams, in particular third-generation cephalosporins, and Bactrim have documented efficacy, but resistance levels climbing. You should see improvement relatively fast, 1 to 2 days. If you don't get improvement, you want to culture the stool and then susceptibility test your organism and adjust your regimen. There's no vaccine available. Several are in development. It's difficult to know if this will ever fly. There is a non-absorbable version of rifampin called rifaximin. That's an effective prophylactic against Shigella. And if you're traveling, this is a good drug to take with you and use. Now, Shigella, please understand, it's reportable. You have to contact the CDC. If your organism is multi-drug resistant, it has an enzyme that degrades lots of different beta-lactams, the extended spectrum beta-lactamase. There's a good test you could do for that. Then you need to seek special advice. Carbapenems may work in such cases. Cefepime might too, so might astrianum or Zosyn. These new drugs, there's just little data to recommend them so far. Doxycycline, tigecycline might be acceptable alternatives. If you have a patient who's pregnant, you can't use these drugs because of bone softening and tooth deformities and things like that. The next organism I'd like to talk about is Vibrio cholera. So Vibrio is a waterborne organism. You get it through poorly managed water supplies. It's not uncommon to see Vibrio outbreaks after storms where the sewage system will get overrun by seawater. This is an organism that is a marine organism. The genes for pathogenesis are not encoded on plasmids like you see in E. coli, rather they are chromosomal. So the organism makes a mucinase, so it degrades the mucus covering of your GI tract and it attaches by means of special pili. There's two different special pili. The TCP, or toxin co-regulated pilus colonization factor, and ACF, which is accessory colonization factor. Those are special fimbriae that are used for attachment. The flagellum may also play a role in attachment as well. It's then that this organism releases the very, very powerful cholera toxin. So this toxin will cause cells to produce large amounts of cyclic AMP. By producing large amounts of cyclic AMP, they cause enormous efflux of chloride. And with this enormous efflux of chloride, you also get large release of water. So you get an abrupt vomiting and diarrhea anywhere from a few hours to a few days after the infection. Fluid losses from cholera can range from 15 to 20 liters per day. So hypovolemic shock and metabolic acidosis are quite common. The eyes and the cheeks of the patient will appear shrunken. The hands will kind of get that prune-like appearance, like after you've washed dishes for several hours. Mortality rates can be 60% and even above. To culture the organism, you use thiosulfate citrate bile salts agar, TCBS agar, and the colonies will appear yellow on this agar. Replacement of fluid loss is essential. So mild cases can be treated with standard oral rehydration formulas. Rapid correction of severe hypovolemia is life-saving. You'll replace with isotonic fluids. And so the oral electrolyte replacement, if your patient can still take fluids orally, you give a potassium chloride or potassium bicarbonate solution. You give solid food only after the vomiting stops and the appetite returns. There are very good formulas for the oral rehydration treatment. To treat this organism, doxycycline is a very good treatment. You usually start with a very high dose, usually 300 mg, either once a day or 100 mg twice a day, then 100 mg once a day on days 2 and 3. If your patient is pregnant, azithromycin works. Ciprofloxacin is another drug that you can use as an alternative. Likewise, you can use Bactrim as well. The big thing you need to use, however, is the oral replacement, oral rehydration. Vibrio parahemolyticus is a gastroenteritis caused by consumption of contaminated shellfish. So there was a report in 2013 from the CDC of people who acquired this infection from eating undercooked oysters and clams. You can also get it from undercooked shrimp and prawns and lobster and things like that. The infection occurs within 24 hours after ingesting the bacteria. You usually get a watery diarrhea, abdominal cramps, nausea, vomiting, fever, headache, and bloody diarrhea. This will last from 1 to 7 days. Treatment is usually not necessary. Severe illness is rare. It occurs most often in people with weakened immune systems. If a patient does need treatment, then doxycycline and third-generation cephalosporins treat it quite well. It's difficult to culture this organism. You can't really culture it from the food. So the association with undercooked shellfish is the tip-off with this particular infection. Now we come to E. coli. So E. coli causes several different types of gastroenteritis infections. So E. coli, it depends on the strain. So there are ETEC, which stands for enterotoxigenic. Then there's enteropathogenic E. coli. Then you have enteroaggregative. And you have Shiga toxin producing E. coli. And then finally, enteroinvasive E. coli. So these, they cause gastroenteritis. E. coli, of course, also causes UTIs. We talked about that before. They can also cause sepsis. They can cause meningitis. And they can cause an enterotoxicosis. So these are the types of infections E. coli can cause. Let's take a look at the different types of infections caused by these different types of E. coli. All right, first, enterotoxigenic E. coli. So this is a so-called traveler's diarrhea. This is called lots of colorful things, Montezuma's Revenge, the tourist trots, blah, 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 so on and so forth. You get a watery, non-bloody diarrhea. And this is caused by either enterotoxigenic E. coli, or it can be caused by the entero aggregative E. coli as well. So you get a watery diarrhea. There are no PMNs in the diarrhea. And there are other organisms that can cause this. Norwalk virus can cause this. Some salmonella infections can cause this. Some Campylobacter infections can cause this. If you're traveling, this is usually the type of infection that you get. It's caused by enterotoxigenic E. coli. So the organism attaches to the intestinal mucosa. After it attaches to the intestinal mucosa, it will make a couple of toxins. There is a toxin that is heat labile, is destroyed by boiling. There's another toxin that's heat stable. And these are going to essentially work like cholera toxin. You get increased cyclic AMP and you get increased chloride efflux and you get diarrhea. This is usually self-limiting. There's not usually a need to treat this. The organism usually will work its way through your bowel, and it's usually of no consequence. If you're traveling, it can be extremely inconvenient and even embarrassing, having to run off to the bathroom all the time and what have you. Again, you can take azithromycin prophylactically. But it usually does not require treatment. Your enteropathogenic strains, these are usually going to cause diarrhea in children. And you tend to see it in developing countries. So these have the ability to adhere to the intestinal wall. When they adhere, they do this really interesting sort of thing where they will cause the velar folds of the small intestine to collapse into these little pedestals. And the bacterium attach and they inject toxins and they cause the cytoskeleton of these cells to rearrange so that essentially these cells now form little pedestals. And here's a little picture of these pedestals essentially. And so this is very characteristic of your enteropathogenic. And these can essentially cause some good deal of destruction of the intestinal microvilli. It's actually not uncommon for people who are not lactose intolerant to now be lactose intolerant after an episode with enteropathogenic E. coli. Stools will contain mucus but no blood. So you got diarrhea, vomiting, usually fever with malaise. You get breaks in nurseries and what have you. And again, this behavior of these cells is due to injection of effectors by type 3 secretory machinery in these cells. And they these types of infections, again, they tend to be usually relatively self-limiting. Treatment is usually not necessary. The other issue with treatment is that because treatment kills off normal flora, treatment can make the disease worse, so treatment is usually not recommended unless ready to die, unless the disease is life-threatening. Also, extensive work has failed to demonstrate that antibiotics decrease the incidence of the disease. And again, your enteroaggregative, this is also leads to a tourist type diarrhea, traveler's diarrhea, TD. You get this in Mexico from food vendors. So you get it in salsa. So those of you who've been to Guatemala, they may have told you don't eat the lettuce because the lettuce has enteroaggregative Escherichia coli. So salsa, your fruits and vegetables, and what have you, desserts. That's essentially, and these cause the traveler's diarrhea as well. Again, there's no need to treat these. Usually, if it's really severe, your best bet is a fluoroquinolone. Now, if your organism is a Shiga toxin producing E. coli, or if it's an enterohemorrhagic E. coli, these bacteria will make the same toxin that Shigella makes. And the most common of these strains is your O157H7. And O157H7 is responsible for some of the more severe foodborne outbreaks of E. coli. So if you hear in the news about contaminated romaine lettuce causing severe E. coli outbreaks, that's almost always O157. And these are almost always these enterohemorrhagic strains of E. coli. CDC estimates that the Shiga toxin expressing E. coli causes over 250,000 deaths, illnesses, over 3,500 hospitalizations and 30 deaths each year in the US. And so this usually you'll have very bad stomach cramps. You think you're going to die. Diarrhea that is usually bloody with vomiting. There is a fever, but it's usually not terribly high grade. Most people get better within 5 to 7 days. Others will get infections that can be life-threatening. And in cases like this, where the disease can get a lot worse, it's usually because the absorption of the toxin leads to hemolytic uremic syndrome, which is a type of kidney failure caused by the absorption of the toxin. And in this case, the patient, this is 5 to 10% of patients who get the Shiga toxin expressing E. coli. So these people will have decreased urine output. They'll feel very tired. They'll lose the pink color in their cheeks and on the inside of the lower eyelids. These people, if they get HUS, they need to be hospitalized immediately because their kidneys may stop working. That will affect other organs. Most of these people will recover, but they may suffer permanent health problems. They may even die. Depends on their kidney health beforehand. Also depends how quickly they get hospitalized so that they can be put on temporary dialysis, fluid treatments and things like that as well. Again, data has not shown the efficacy of antibiotic treatment in the cases of enterohemorrhagic E. coli. Doesn't alter the duration of acute illness, and it's been associated in some cases with the development of hemolytic uremic syndrome in some cases. So treatment is not recommended, not recommended. Okay, and that leads us to the enteroinvasive E. coli. So with this one, you have invasion of the intestinal wall. Just like you have with Shigella. And so duration of this illness is about 7 days. You shed organisms usually for 6 days. And treatment does decrease duration of symptoms. And just like Shigella, this infection begins in the colon. And it gets phagocytized by macrophages. They escape from the phagosome. They divide in the macrophage. They escape the macrophage. They infect the basolateral side of the colonocytes and so on and so forth. It's the same story all over again. So the organism is able to penetrate what's taken up. It escapes. It gets infected. It can then also infect the Peyer's patches, and then it can infect the basolateral side, or it can infect laterally other cells, and that's how you cause destruction of the intestinal mucosal cells. That's why you get the bloody diarrhea. First choice of treatment is your fluoroquinolones. Azithromycin is a second choice. And third generation cephalosporins are your third choice of treatment. But resistance is a big problem. And that is mainly the other reason why treatment is just not recommended. Because it's not going to do any good and it just kills off your normal flora. All right, there's your E. coli. Okay, we got through our bacterial enteritis section. We now got at least the more common ones. We still need to cover Helicobacter pylori, Campylobacter. We also need to talk about some of the viral infections and what have you, and then Clostridium difficile. I will probably end up podcasting that, and then I should probably also talk about appendicitis, diverticulitis, and things like that, peritonitis. So that'll probably get podcasted. It's just time. We don't have much time. We still need to cover the blood-based infections and then the nervous system infections. We only have 2 days left. So I'll probably podcast the rest of this. So hopefully then we'll start on the next chapter on Friday. Okay. I will see you guys on Friday. And I'll hang here if any of you have any questions.